Okay, so a little about temporal silicon spleen. I hope you know it, you remember it from clinical classes. From time to time, we make it first type. That is, of course, temporary spleen, but in our survey, we checked how it works, and the aim of our study was to evaluate the influence of temporal silicon splint application on the symmetry of masticatory muscle activities during clenching using surface electromyography. And results are very interesting. We used electromyography to check function of masseters and temporal muscles. So electrodes were put on the skin under these muscles to check the masticatory muscles functions and electromyography results. And we observe symmetry in function when we compared the results without the splint and with split. So conclusion, application of temporal silicon splint reduces double side imbalance of masticatory muscles during clenching. The mechanism of action of silicon splints may be partly explained by the effect on masticatory muscle activity. Chair-side fabricated silicon splint may be as a cost-effective simple method for initial treatment of TMD, and the influence of temporary silicon splint application on long-term effects of treatment requires, of course, further research. But generally, it's low-cost methods. Of course, for us, it's not oral appliance for long use, but only for, we can say, first aid, but in cases from time to time also it can be a good method. Next studies also results when we checked the influence of self-stabilization splint on electromyographic patterns in masticatory and neck muscles. Also, conclusions were that soft stabilization splint influenced resting and functional activity of these muscles during tooth clenching. As soft stabilization splint changed the involvement proportions of the temporalis and masseter muscles, transferring the main activity to the masseter's muscles. And using of stabilization splint did not affect the symmetry of electromyographic activity of masticatory and neck muscles. So we can use this method as temporary first step of treatment. But here you have another method, and it is individual appliance, because it's rather not splint, but appliance. It is relaxation sublingual plate. Maybe you made it in your patient during classes, but it's indication for use specific because we made it rather for patients and only for patients with muscle problems. And this plate is how to make it. Of course, we have to make impressions of our upper and lower arches, and this plate put it from the lingual side in, of course, lower arch. What is the range of this plate? The upper range of this plate runs along the incisors edges of incisors and canines, and on the anatomical equator of premolars and molars. And lower range of this plate runs along the inner oblique line on the right and left side, avoiding the frenulum of the tongue. So it's a little like a range like or lower range of this plate, similar to the range of dentures. And the thickness is more or less about 2.5 millimeters. Of course, this plate shouldn't interfere with occlusion. So when we look at models from posterior side, we see that it doesn't interfere occlusion during centric contacts and during eccentric mandibular movements. So, of course, it can be made of acrylic resin with, like here, it can be different colors, but in most cases, it's not harmful. And like here in these patients, you see that this plate does not interfere with occlusion. How it works. So putting this plate will correct the position of the tongue. So thanks to changing the position of the tongue, the mandibular will go to the correct relaxing position. So, of course, when we put something from the lingual side, the space of the tongue will be limited. And as a result, we have changing in position of the tongue, so moving the tongue up and forward. We observe mandibular translation. Of course, thanks when the position of mandible will change to the relaxing correct position, we also observe changing in position in temporomandibular joints. As a result, we will receive relaxation of the masticatory muscles. Thanks, as a result, finally, as a result is limitation of pain. So, muscle relaxation as a result of relaxing sublingual plate was conferred by electromyography, and we results of survey by Korolewski, for example, showed us decreasing in muscle electromyographic activity of masseters and also anterior parts of the temporalis muscles. So, our hypothesis about mandibular repositioning as a result of treatment with relaxation sublingual plane was objective biometric method based on cephalometric teleradiograms analysis made by Nadal IT. So, results of and good results observed in clinical practice were confirmed by also by studies. So it's a good method, but it's a method for particularly for problems with muscles, not rather in temporomandibular joints. Okay, so we have, I think, now everything about occlusal various types of appliances, and now I would like to continue talking about treatment and about more other methods of management of temporomandibular disorders. Okay. Okay. Okay, so I was talking about it last week, that generally we try and we start from non-invasive management. And of course, a very important part in all treatment play has behavioral therapy. So what it means? Stress management, biofeedback, but also psychotherapy or hypnosis. But also here in this group of methods, we have physical therapy, we have pharmacotherapy. So today I would like to say more about these methods. About patients' education and self-care, you were talking a lot during classes. It was the subject of first class in the semester. So you know that changing in patient's behavior, avoiding some parafunctional habits, harmful for stomatognatic system is very, very important in the treatment plan. It's patient's our partner in treatment, so the patient will help himself and herself, and it's not possible to receive good results without working and some changing in behavioral in life made by our patients. Various types of cognitive behavioral intervention also is important. It's important part of the overall biopsychosocial treatment program. Sometimes here we have a combination of biofeedback, relaxation also technique, of course self-directed lifestyle changes, and from time to time our patients will need some psychological intervention also. And education, our patients also very important part. But what we can also add, supportive therapy. It is treatment that is given in additional to the primary, main or initial treatment. And what we should remember that supportive therapy is only symptomatic and not a replacement of definitive therapy. When we would like to divide it, we would like to divide this method. We can divide these methods into physical therapy, pharmacological therapy, and behavioral therapy. I mentioned previously. So physical therapy, here we have various types of therapies like manual laser therapy, iontophoresis, electrical stimulation, also acupuncture, and ultrasound and thermal therapies. In pharmacology, pharmacological therapy, we sometimes need to use some drugs like painkillers, also anti-inflammatory drugs, psychotropic drugs from time to time, and muscle relaxants. In behavioral therapy, of course, general stress management, biofeedback, cognitive behavioral therapy, psychotherapy, and hypnosis. From time to time, also we showed patients some therapeutic exercise to correct muscle function. Also some special exercises for patients can do at home, and it is also one method of our therapy, therapy. We try to by these methods, we try to correct the mobility of the mandible, to strengthen the muscle, to correct balance between left and right side, to correct the range of mandibular opening and other mandibular movements. So it can help to correct the mandibular function. Sometimes also we used these methods like exercises in case of too wide of a mouth opening. So here we have patients with subluxation where the range of mandibular opening is more than 50 millimeters, sometimes 50, 60 even millimeters, and from time to time, in these cases, we observe subluxation, so the patients are able to open so much, and sometimes they have problem to close. So we have lock in temporomandibular joints in maximum opening position. So then we can ask patients to make special exercises where we ask patients to put the tongue on the palate and with this line, with this tongue on the palate, we ask patients to open to the moment when the patient is able to fix the tongue in this correct position. So repetition from 15 to 20 times and making these exercises repeated 2 to 3 times a day after weeks, after months, should correct the mandibular opening, and the range, we should observe that the range will decrease. There are also a lot of manual techniques. These techniques are divided into 3 categories, like soft tissue mobilization, joint mobilization, and muscle conditioning. Massage therapy is for generally for myalgia, for pain in muscles, and it can be relieved by massage therapy, which leads to re-establish the proper flexibility and muscular length, and because of it we observe that the pain should decrease. And with massage therapy, the patients can also make at home, of course, after first the physiotherapist should explain some special procedures and teach patients how to do it, but it can be a part of general management of temporomandibular disorders, and it can be part of self-management. So here you see various types of movement in massage procedure, like kneading, friction, stretching, and generally results of these methods. What is the results? It's warming up the muscles. In this way, we provide blood and lymph flow. We observe increasing blood level in the massage's tissues. So generally, thanks of these methods, also we observe increasing the range of movements and also pain relief, decreasing muscle contraction. And generally, the pressure used during massage must not be too intense, should be increased over time at each therapeutic session, because therapy performed too strongly may lead to increased muscular tonus. Massage, of course, it depends on the case, but can be performed twice a week. Sometimes it depends on the patient. It can be not so often. Sometimes it's enough to do it only one a week, and physiotherapists may also sometimes recommend heating or cooling of the affected muscles, because this therapy with sometimes using some special okay. So of course also sometimes we advise our patients to change food consistency, so eating softer food, applying cold and heat on under the muscle with pain, avoid extreme movements of the mandible like gum chewing while yawning or loud singing. So all of this information are very, very important. And special manual therapy is only methods is method which is used only by physiotherapists and is most commonly used in disc displacement. So it involves special traction or sliding movements, and as a result, for example, when we have cases with this displacement without reduction, so as a result, when it's not long, one is quickly made after this displacement, sometimes it's very good methods to for a position of disc. So here you have some special information about these methods, but I think it's rather a special technique using by physiotherapists. So rather we don't do it as a dentist. And other physiotherapeutic techniques like biofeedback or lamp exposure or phoresis, in this methods we have to use some special devices, so it's not manual but we use special equipment. So for example, biofeedback, it's very interesting method because using this method, so a patient you work and learn how to control function of masticatory muscles, how to relax these muscles. We do in this method we use special program for PC and electromyography. So here you see on the slide that the patients are sitting and looking at the computer monitor, but on the skin under the muscles, maybe here you will see it, we can put some special here we don't we can put special electrodes, and the patient can see the muscle information from these electrodes on the monitor and can control the muscle function. So looking at the monitor, the patient should try to relax muscle and observe the results of the monitor. Maybe here, yes, here we have various physical therapy modalities using some special devices like thermotherapy, coolant therapy, ultrasound iontophoresis, TENS, acupuncture, and laser. And we start for low-level laser therapy. In recent years, the cold or soft laser has been investigated for wound healing and pain relief. Currently, it is not considered to be a routine physical therapy modality. Most studies on the cold laser report on its use in chronic musculoskeletal, rheumatic, neurologic pain condition. So, how it works? So, it is thought to accelerate collagen synthesis, increase vascularity of healing tissues, decrease the number of microorganisms, and decrease pain. So also we can use this laser therapy because of these results, or we can use these methods also in our patients with TMD. So it can be used for temporomandibular joints and for muscles. Very interesting method is iontophoresis. It's a technique by which certain medications can be introduced into the tissues without affecting any other organs. Because from time to time we use anti-inflammatory drugs, painkillers. We prescribe these drugs for our patients, but of course sometimes we observe some side effects when this because of side effects. Sometimes we are not able to. We shouldn't prescribe these drugs, but we can use it with iontophoresis. So the medication is placed in a pad, and the pad is placed on the desired tissue area. So, for example, in pain in temporomandibular joints, it's a very good method. For this method, in most cases, I prescribe anti-inflammatory drugs like ketoprofen, and we observe very good results and pain relief. Electrical stimulation is next methods for masticatory muscles. So transcutaneous electrical nerve stimulation is produced by a continuous stimulation of cutaneous nerve fibers at a sub-painful level. Also it's interesting methods. These units have been developed for long-term use by patients with chronic pain and can be effective in various TMDs. So here you see this small device with electrodes. These electrodes are put under the skin, on the muscles. And of course, it's not possible to use this methods for all masticatory muscles, only these, like here, masseters, anterior part of temporalis muscles, of here also in others, but in most cases we use it for masseters and temporalis. And this good methods is well known for pain relief, and maybe we have only a small number of studies. Um, so this method cannot yet be considered a standard treatment for TMDs, but in clinical practice we observe it as these good effects. And also acupuncture, maybe in our country also this method is used. Of course, it's a common method in Asian countries, and it's, I think, most common in this part of world. But a modern approach of needle puncture is based on the findings of trigger points in painful muscles. So when we, during palpation, when we find points during pressure very painful, these points are named trigger points. And in this method, in acupuncture, dry needles are inserted at the trigger points. And I think it's not very clear to explain how it works. Maybe it's not very, very good known from the scientific point of view. This method is not very good described, but it's one of method which can be also used in TMD patients. And maybe when this acupuncture is a little similar to TENS. Although acupuncture TENS seems to involve similar mechanism, some evidence suggests they are physiologically different because in acupuncture seems to use endorphins also for pain modulation, whereas TENS may not. But these methods are a little similar. So there are some special points in these points with acupuncture needles are put. These points are on all body, but also a lot of these points are in area of our face. And next, ultrasound therapy also is one of the efficient methods for pain reduction, decrease in muscular tonus, and improving function of the muscles. So it consists of different types of signal, constant waves, sound impulses, and ultrasound combined with stimulation current, which is found to be most effective. So also this method is used particularly for muscles. This therapy can provide significant relief of symptoms for many patients. It first increases the temperature of the interface of the tissue and thus provide a deep heat. So ultrasound is a method of producing an increase in temperature in the interface of the tissues, and therefore affects deeper tissue than does surface heat. Not only does ultrasound increase the blood flow in deep tissues, it also seems to separate collagen fibers This improves the flexibility and extensibility of connective tissue. Some experts have suggested that surface heat and ultrasound be used together, especially when treating post-trauma patients. So also in some cases we can add these methods to the treatment of our patients. But a very good method is using for pain release heat. So a special lamp like Solux lamp can be used. In Poland, it was, I think, many years ago, this lamp was very, very popular. Also for not only for temporomandibular disorders, but other problems with pain in various tissues in all our body. Also, cryotherapy is another form of temperature-related therapy, but applies as cold instead of heat. With cold pack you can buy. Also, there are cold spray. So the application of cold is used immediately prior to kinesiotherapy and helps fight muscle hypertension. So sometimes we can advise that the patient, before they will make some manual massage, can put heat pack or cold pack and then start massage. And of course, occlusal therapy, a little about it, because nowadays we don't make correction of occlusion for in treatment of temporomandibular disorders as quickly as we do it previously. But sometimes when we have patients with missing teeth, when we have what our patients will need prosthetic dentistry, of course, it's also the part of occlusal therapy. So sometimes we have to make some special dentures, crowns, bridges to correct the generally to correct dentition. And once again, the scheme of clinical or planning of treatment from clinical point of view, when we have first clinical examination and interview, and in cases with myofascial pain or cases with internal derangement of temporomandibular disorders, we can use splint therapy, but also physical therapy, pharmacotherapy, and in cases when we don't observe very good results, we can consider alternative therapies, like, for example, surgical therapy for temporomandibular joints. But first, we start from conservative, from non-invasive methods. Here also on this scheme we have once again the step-by-step information about possible methods of therapy when one method will not work when we can go to another methods. And finally, surgery is the indicated treatment for a very, very small percentage of temporomandibular disorder patients. And of course, only those with specific TMD articular disorders. And we have surgical management from closed surgical procedures like arthrocentesis or arthroscopy, or open surgical procedures like arthrotomy to even some others like condylotomy. Most, maybe first step, most non-invasive in these all invasive therapies is arthrocentesis. So this method involves draining the joint with a therapeutic substance, reduces the inflammatory process, evacuates inflammatory exudate, releases the disc, breaks up adhesions, eliminates pain, and improves joint mobility. Of course, like all surgical procedures, also this technique has limitation due to low tolerability and difficulties in performing the procedure, and we have single or two needles arthrosynthesis, but in most cases more simple or more or less invasive is this single needle arthrosynthesis. So it's this method is more popular. And we have here injection. The point of injection is located about 1 centimeter below the apex of the zygomatic arch. So in this point we put the needle in maximum opening position of the mandible, and we can only, for example, rinse the joint using this method, or also we can put some inflammatory drugs. But what are results when this method is compared to not invasive methods? So in this randomized control trial carried out by VOS, this method tried to determine the effectiveness of arthrosynthesis compared to conservative treatment. So like oral appliances. And they showed that arthrosynthesis reduces pain and functional impairment more rapidly, of course, compared to conservative treatment. But in long-term observation, the effectiveness of both treatment methods achieved comparable outcomes. So finally, results are similar. Of course, surgical methods are from time to time some side effects, but of course it's also one of the possible methods. Pharmacologic therapy the indicated classes of pharmacologic agents include analgesics, anti-inflammatory agents, corticosteroids, anxiolytics, muscle relaxant, and also low-dose antidepressants. We can also use these drugs in injections intra-articular joint injection of, for example, corticosteroids also is recommended from time to time, but also we can prescribe it in pills. Sometimes we see that not only anti-inflammatory or painkillers are prescribed, but in some cases of patients with generally more psycho-emotional problems, also other groups of drugs should be used, like even benzodiazepines. Of course, these drugs should be excess antidepressants, and because of side effects, shouldn't be used for long-term use. Then other types of antidepressants, if it of course is important, or when the patient should use it, should be prescribed. Also, muscle relaxants, sometimes for acute muscle pain. In these cases, also sometimes we prescribe. Very important, we in our daily practice, we prescribe this medication, but not very often, because it's important to take into consideration also general health and condition of our patients. So very often we have to consult our patients with physicians, because particularly when our patients in the history talk about various types of general diseases. And most often we prescribe painkillers. So it is important part of supportive therapy in disorders in which deep pain input is actually the cause of disorder. Analgesic represents a definitive treatment, and rather not often we need to prescribe something more than typical pain killers, like, for example, paracetamol. But if it's not enough for our patients, we should sometimes to consult our patient with specialists who will prescribe special drugs for, like, opioids, narcotics, and these doctors who treat patients with not acute but more serious general pain. Here you have different non-opioid analgesic. Also, sometimes we use it like aspirin. Important is that there are some also side effects, so we have to also take a good interview with the patients, because the patients with these drugs can have side effects for digestive indigestive problem, non-steroidal anti-inflammatory drugs, corticosteroids, also are prescribed in these cases. I think that very information details about these drugs are not important so much, but ibuprofen, I think it's a good and very common drug for our patients. This drug has first anti-inflammatory effect, should be taken for a minimum of 2 weeks, and a common dosage is from 600 to 800 milligrams 3 times a day. So in cases when we have local myalgia, pain in temporomandibular joints during mandibular movements, we can first start from this drug. And of course, like for aspirin, and also in this case, using these drugs may result in stomach irritation. So it's very important that in our patients sometimes who have problems with stomach, we should ask about general health, because when we have patients with stomach irritation, we can use, for example, ketoprofen in the form for iontophoresis, for example, of temporomandibular joints. And corticosteroids, anti-inflammatories, not commonly prescribed for systematic use in the treatment of temporomandibular disorders because also of their side effects. But when we have patients with general problems, like, for example, polyarthritis, then these patients these patients will use these drugs, but rather this general treatment will be conducted by the general specialist, not by the dentist. And these psychotropic drugs. Also, these drugs, sometimes our patients will need these drugs, but we will, as dentists, we will not prescribe antidepressant or anxiolytics, but from time to time we should receive that after interview, after clinical examination, when we use all questionnaires from EXIS-2, from diagnostic criteria of temporomandibular disorders, we should also consult our patients with psychologists or psychiatrists, and then they will conduct the correct also pharmacological treatment, and they will prescribe these drugs, because it's not our area of I think even knowledge. But here generally we know that emotional status of our patients will be very, very important, and when our patients we can make a perfect spleen, we can make or conduct some physiotherapy, and without some additional methods like pharmacotherapy in patients with depression, anxiety, these results will not good. Muscle relaxant also from time to time in situation where we have problem in our therapy. Also, we can ask our colleagues, general doctors, to add some others pharmacology, like muscle relaxants. And a little about botulinum toxin type A, because it's nowadays very common methods, but rather in medicine, when for aesthetic medicine, but now also from time to time we use these methods for myofascial pain, because this botulinum toxin type A will reduce muscle tension. It is a biologic neuromuscular blocking agent that works as a muscle relaxant and therefore relieves pain in head, in neck. Of course, it's not first method. It's not first method in treatment of temporomandibular disorders in Braxers. Sometimes we have a problem to in our treatment, the tension, muscle tension. We are not able to relax these muscles using other methods, and then we can think about injection of botulinum toxin A. But of course, it's not first step of our treatment. And now maybe one interesting, I would like to show you something interesting from cases. I have to close this presentation, and I would like to show you how important it is to diagnose our patients in details, because sometimes our colleagues from our others department ask patients to consult not easy cases, and here you have one of them, because it was a case of patients, female, with mandibular mobility dysfunction and the possibility of misdiagnosis based only on the clinical examination. So this female was aged 29, was admitted to our department with restricted mandibular movement and pain in the area of the right and left joints. So in the history, the left mandibular third molar was extracted, and it was not very easy extraction. The dentist, after extraction, the dentist drained the abscess intraorally and prescribed antibiotic, because some problems with healing was observed. All time the patient felt problems with mandibular movements. The patient also observed an abnormal acoustic symptom and felt pain in the left temporomandibular joint lasting for several days. The patients reported occlusal also abnormalities, the occlusal separation of the posterior teeth on the right side. And in our department during clinical examination, we observed restriction of vertical mandibular mobility to 32 millimeters with a deviation of 4 millimeters to the left side. Lateral movements are also limited, 3 millimeters to the right and 7 millimeters to the left. Protrusion range also was limited to 3 millimeters with deviation of 3 millimeters to the left. And also we observed reciprocal clickings in the right joint. In the left joint, pain, but no acoustic symptoms. And during palpation, we revealed pain in the articular area. Also, intraorally, we found a centric occlusion dysfunction in the form of posterior disclusion on the right side. So, from on panoramic radiograph made in December, we found osteolytic foci in the left ramus of the mandible. So there is an irregular outline also of the posterior edge. And what was our first preliminary diagnosis? This diagnosis was made based on the clinical examination only. Because we are department of dysfunction, temporomandibular dysfunctions, most cases are in our department are patients with this problem. We thought about this displacement without reduction in the left temporomandibular joints. But in order to evaluate the position of condylar heads of the temporomandibular joints, and also because we wanted to control this osteolytic foci, we found on panoramic radiograph, it was indicated that TMJ X-ray in maximum intercuspation and disclusion should be taken. And what we found? We found pathological fracture of the mandibular condyle. So it was not typical problem, functional masticatory system, but this was pathological fracture. So clinical symptoms are very similar to clinical symptoms of disc displacement without reduction. Only thanks to X-ray examination, we found the general problem. And of course, the patient was referred for further diagnosis and treatment to the Department of Maxillofacial Surgery, and histopathological examination of the removed tissues revealed bone sequestra and, of course, chronic inflammatory cell infiltration. So it was the patients for surgical treatment, not for functional treatment of temporomandibular disorders. So you see how important is interview, clinical examination, but also others method of examination, not only clinical, but for example, X-ray evaluation, in other cases MRI. So thanks to this method, step by step, we are able to find the main problem and plan the correct treatment of plan correct treatment. Okay, so now I think that we will finish our lecture. So next, because we have 5